Okay, so we're now starting with Dr. David Baidal, who will present the Poseidon protocol status in Miami.
Thank you so much. Thank you, Dr. Ricordi and the organizing committee for the invitation. So we have had very exciting presentations preceding this, talking about omega-3 and its role on inflammation and potential role on immunomodulation, vitamin D and its role in other autoimmune diseases, and the effects of chronic inflammation in type 1 diabetes. So with all of that being previously said and nicely described by the previous speakers, it kind of makes sense that this intervention should be tested, hopefully in an adequate way, in a setting of a clinical trial to try to answer a particular question. And with that in mind, we designed the Poseidon study, which I'm going to start discuss and provide a little bit of details in the next few minutes. So the Poseidon study is a pilot safety and feasibility trial of high-dose omega-3 fatty acids and high-dose cholecalciferol supplementation in type 1 diabetes. And what we're trying to do is we're trying to test the safety and efficacy of high-dose omega-3 fatty acids and vitamin D3 on preservation, regeneration of beta cell function in subjects with new onset and established type 1 diabetes. The study design, this is an interventional study. It's a phase 1/2A. What does that mean? It's testing two things. First of all, safety. It's a pilot study. It's looking at the safety of this combination. We have to keep in mind that we're using high doses of omega-3s, and we're also testing it in children. And it's a 2A study, which essentially checks for efficacy as well. So it's looking for both safety and efficacy in this particular trial. The estimated enrollment is 56 participants. It's a 2-arm open label, and what that means is that neither the investigators nor the patients are blinded to the intervention. They will know what they're receiving. And it's a single center, and it's a randomized trial. All groups will receive standard diabetes management and dietary management. So the study groups have been designed according to the age of the participants and the duration of diabetes. And keeping that in mind, we have two different groups, which are the adults. Let's see if I can move the arrow here and get there. There we go. We have the adults, 18 to 65 years of age, which will be divided in groups 1 and group 2 based on the duration of the disease. Either their new onsets, defined here up to 180 days of diagnosis, or established disease, which goes beyond that time frame and up to 10 years of diagnosis. And group 2, again, so group 1 and group 2 will have this distinction, duration of the disease, and the same is true for the children group, ages 6 to 17 years of age, again, being the established disease group 3, and the new onset group 4. And the rationale for having it divided as such is we want to see whether this intervention has an effect at different stages of the disease, either early on or also down the line after several years of type 1 diabetes, granted that these patients maintain C-peptide, which will tell us that they still have beta cell mass that we can probably rescue down the line. And in a little bit, I will describe why up to 10 years. So what are the study outcomes from this trial? The primary outcome is looking at the 90-minute C-peptide during a standardized mixed meal tolerance test, which is a combination of fat, carbohydrates, and proteins in a standardized controlled environment that we provide to the patient. And we want to look at the 90-minute C-peptide being either greater or equal to what the baseline level was at the 1-year visit for the study. And then, of course, we're going to also look at secondary outcomes, which will be the stimulated C-peptide area under the curve during a 4-hour mixed meal tolerance test. We're also going to be looking at the HbA1c, insulin requirements, and of course, considering that this is also a safety study, we're going to be looking at the incidence of adverse events. So to try to simplify and make this schematic here of how the groups will be divided. So you can see up here the adult groups. Again, group 1 and group 2 being divided based on either their established disease or new onset, and the same in children. So each group will be again randomized. So this is like throwing a coin to either having omega-3 and vitamin D or vitamin D alone. So this ultimately breaks down each subgroup into 7 subjects, right? And the same holds true for each one of the different arms of the study. So it's dependent on age, dependent on disease duration, And once you assign them to the groups according to that, they will be randomized to receiving a combination of omega-3 and vitamin D or vitamin D alone. Treatment will be for 1 year, and after completion of the treatment phase, they will go into a post-treatment phase where they will be followed for another year and reassessed at the end of the study. So I had mentioned the issue of why are we still looking at patients out down to 10 years of the disease? And I think it's important to consider that we have learned, and there's extensive literature, that once you present with diabetes, in the past we had this belief that a significant amount of beta cell function was lost, and ultimately it would be lost quite relatively quickly. But we know that there's a lot of heterogeneity. Many of these patients have a significant amount of C-peptide early at diagnosis, and depending on the age, some progress much faster, others progress much slower, and even up to 10 years, you may still have significant amount of C-peptide, and if you have C-peptide, you could intervene to try to either save or perhaps even regenerate those beta cells. And this is data from the Diabetes Control and Complication trial, which included subjects that had up to 15 years of type 1 diabetes. And you see adolescents and adults here. It's a little bit difficult. I'm sorry to move the arrow, but bear with me for 1 second, and let me just go back. And if you look early on in the disease, this is the stimulated C-peptide, and these lines here provide the threshold of either 0.6 nanograms per milliliter, which is what is typically used for intervention trials in new onset and type 1 diabetes, and when you do randomized controlled clinical trials. And up here is 1.5 nanograms per milliliter. So these patients still have some robust function even early after disease within the first 5 years. As you start going into the 5 and 10 years, clearly you don't have as many, right? The proportion decreases. But you still have a few of them that maintain a stimulated C-peptide above 0.6, and certainly much more that have a C-peptide above 0.1 nanograms or 0.2 nanograms per milliliter, but they're less. This is the adolescent groups. These are the patients that are expected to progress faster and lose function faster. When you look at the adult subjects, no surprise, you have more patients actually that have residual C-peptide, even down the line and up to 10 years. So again, it's not many of them, but we still have a few of them that we could provide them with the opportunity of an intervention that may preserve their surviving beta cell mass and perhaps even regenerate it. This has also been shown in other studies. This is a study by Dr. Oram, published in Diabetology in 2014, again showing that within the first 10 years of disease, you do have patients that maintain levels of C-peptide. So again, that's the reason why we go up to 10 years. Going beyond 10 years, I think the frequency and the incidence of having patients that still have C-peptide is so small that it will take us a significant amount to recruit to find those patients, and most of them will have negative stimulated C-peptide. So what are the investigational products that we are going to be using? Is omega-3 highly purified by Dr. Sears from some labs. And we're going to use vitamin D3, cholecalciferol is the one that we have selected from this particular company, which is biotech. And it will be provided initially as a liquid formulation. It's easier to titrate according to kilo body weight. But if the patient is unable to tolerate the liquid formulation, although there are some options that we can offer them to make it more palatable, patients can be switched to microcapsules. And unfortunately, the issue with the microcapsules is that you will have to take a significant number of capsules to try to maintain the adequate doses. So that's an important consideration. But they are small and usually easy to swallow. So clearly, to come up with a clinical trial, there are different steps that need to be taken for the trial to reach completion just to initiate the study. First, you need to have an IRB approval. You need to have an IND approval. So different things have been taking place for us to be able to start and proceed. Ultimately, after you get your IRB approval and you get your IND approval, you need to have regulatory agencies in place that will make sure that the conduction of the trial is done appropriately in the conduction of human research studies. And we had our pre-study visit in June 2018, and eventually our study initiation visit and training in June 19, and we started enrollment on July 23rd, 2018. So what are the major inclusion criteria for this study? subjects between the ages of 6 and 65, they need to have a diagnosis of type 1 diabetes. We discussed already that they're going to be either new onset, we'll go into a particular group, or established disease, and the rationale for that. They need to have at least one positive islet autoantibody to confirm autoimmunity and islet autoimmunity. And if they have diabetes, if they've been on insulin for 2 weeks, we will not be able to assess insulin antibodies because these patients will likely develop insulin antibodies because of the exposure to insulin. And we are actually looking at a stimulated C-peptide level, as you can see here, is relatively small, of more than 0.2 nanograms per milliliter, but at least it gives us a sense there's still some residual beta cell mass that we're going to try to see if we can intervene and rescue. So a stimulated C-peptide of more than or equal to 0.2 nanograms per milliliters during the mixed meal tolerance test. What are the major exclusion criteria? We want to avoid patients who are obese because that can put in a phenotype of insulin resistance or type 2 diabetes, which may confound results and interpretation of the data at the end of the study. If the patients are taking or are anticipated to take other diabetes medications other than insulin, administration of vaccinations within the previous 6 weeks, concomitant therapy of other immune agents, as you can see there, pregnancy or breastfeeding, in fertile patients, the unwillingness or inability to use a form of contraception. We're not testing the effect of this during pregnancy, so that's why we want to provide and make sure that our patients are using some form of contraception. And history of coagulation, bleeding or blood disorders is important from the perspective of the use of the high dose of omega-3 fatty acids, and I'll get into that in a little bit. So we have nicely reviewed information presented by Dr. Sears in terms of the fish oil, the omega-3, and the effects on inflammation and on cytokines. But let me now switch things a little bit from the perspective of safety also, because I think it's important that we understand how much can we give, where are we getting into a little bit of a danger zone, and repercussions in children, and has this already been tested? Do we have some literature that actually provides information about children using high doses of omega-3 fatty acids? So that's what I try to clarify in the next few minutes. So this particular study, already shown by Dr. Sears, nicely showed that these were adult patients, as you can see here, 28 years of age. They got a huge load of fish oil. This was 18 grams of marine lipid concentrate, right? And they were able to drop the AA-APA ratio to 2.4. There were no side effects. So at least from a perspective of safety, they were safely able to get down to 2.4, but this was a very short study. But it also gave us information that probably you need to get to that range to have an effect, at least from an inflammatory perspective, on reduction of cytokines. So we know that you can probably safely get them there and have an effect, right? But this is short, was a short treatment course. What about keeping adult patients, again I'm focusing on adults right now, on longer duration of omega-3 fish oils? Is there a problem, right? So this was a study looking only at EPA. This was not EPA and DHA, but it was looking at EPA on major coronary events in hypercholesterolemic patients. It was a JELLY study. It was a randomized open-label, blinded endpoint analysis study. It was a very large study, almost 19,000 patients who had very high levels of cholesterol. These were recruited in Japan. They were randomly assigned to getting either EPA, 1,800 milligrams per day. So this was not a weight dose, they were not aiming for a particular ratio. This was the standard dose was 80 milligrams of EPA. And they were either getting that combined with statin or statin alone. And it was a 5-year study, right? So this was chronic exposure to getting this dose of EPA. And the endpoint in this particular study was looking at cardiovascular outcomes. And it nicely showed a reduction in cardiovascular events. You can see here, this is the control group and this is the treatment group. And this benefit was mostly driven from secondary prevention, which means patients that already had a coronary artery cardiovascular disease prevented by taking this dose of EPA another event. So it was very successful just by giving EPA in these patients. But how about problems in terms of side effects by giving EPA for this duration of time? And if you look at this slide, you will see that in the treatment group, which is on this particular side, you had more gastrointestinal disturbance, nausea, diarrhea, epigastric discomfort, which was significantly higher in the treated group, although the incidence is relatively low. Another important aspect was some skin abnormalities. higher in the treatment group. And this was significant, but again, only 1.7% was the incidence. But the most important thing when I saw this paper that caught my attention was the increase in hemorrhages, cerebral, fundal, epistaxis, and subcutaneous hemorrhages that were higher in the treatment group. Although, again, percentage is very low, and this was statistically significant. So the question is, did the ratio have an impact in terms of having these problems? And when you look at the ratios, you can see, first of all, what catches the attention, this population to begin with had a very low AA-EPA ratio. Look at that, 1.7 and 1.6 at baseline. And that's because the Japanese population is used to having a very high amount of fish in their diet. So you can safely, just from diet, get to this particular ratio. But if you look at the treatment group at study end, the ratio was less than 1. So maybe trying to push it that low is a problem. And in our particular trial, we're not pushing it to that point. Our lower limit of the range is 1.5. So I want to highlight this because, again, we need to make sure about the safety of the conduction of the study. And I think we have a measure that we're monitoring. And by keeping the range and the ratio within this particular range of 1.5 to 3.0, I think we're not only looking at the effect and some efficacy, but also trying to ensure safety. So again, a level less than 1 is probably a problem, but 1.5 to 3.0 it may have an effect clearly, and probably is likely to be safe. So how about the data in children? So the previous data that I've shown you is in adults. Now let's look a little bit in children. And most of the data in children stems from the psychiatric literature. And this was a study when they're using fish oil to treat attention deficit hyperactivity disorder. These were 31 children, and the youngest one was 3.5 years old, up to 16 years of age, right? And they had 36 match controls. And the dose here of omega-3 fish oils was 2.5 grams per day per 10 kilo body weight. This was not a low dose, right? 2.5 grams per day per 10 kilo body weight. And the primary outcome was improvement of the clinical psychological condition of inattention and hyperactivity behaviors throughout a particular scale used in psychiatry. So more than looking at the effectiveness, my focus was seeing what was the ratio that these kids were able to get without having any side effects. And you can see here that they were able to get to a ratio of 4.1, and there were no side effects. And you have a child as young as 3 years old getting a relatively good dose of omega-3 fatty acids, getting down to a ratio of 4, and tolerating the procedure without side effects. So there's literature already in children about the safety and being able to push the ratio at least to this particular point. And from an efficacy perspective, these patients that actually were on the treatment actually did better from an ADHD perspective. So with that being said, let me now shift into our clinical trial. One of the strengths, I think, of this particular study is that we have a biochemical marker that we can follow to adjust the doses as opposed to just having an intervention that of one size fits all. Everybody gets this particular dose, that's it. So we actually have a way to adjust and see whether the adjustment, again, ensures safety and may have an impact on efficacy. So the initial dose, as previously already discussed, is 150 milligrams of combined EPA-DHA per kilo per day, and the dose will be adjusted to maintain a target AA-EPA ratio of 1.5 to 3.0, and the ratios will be monitored monthly until achieving target levels, and as per protocol or as clinically indicated thereafter. So if there's any particular concerns, we can always recheck. This is a very simple test. It's done from a blood sample, and then we can adjust the doses accordingly. And vitamin D3 is also, although we all know about the effects and ultimately generally safety with recommended doses of vitamin D, if you overtreat a patient with vitamin D, you could cause toxicity. And one of the main concerns is increasing calcium and causing calciuria, which is calcium loss in the urine, the potential for kidney stones. But that is in patients that are receiving high doses, levels are not being monitored, so that and calcium levels are not being checked. But if you do this in the context of a clinical trial, where you're giving a dose and you're aiming for a particular level and you're checking the calcium, you will ensure that that doesn't occur. So our patients will be given a dose according to their levels in the blood. We're going to target a level more than 40. And I'm going to make sure that the calcium levels are checked so that we ensure that they're fine and there's not an issue with calcemic effects of vitamin D. So again, focusing on safety and again, as well on efficacy. Now there is a busy slide, I apologize, but this is a schedule of events looking at how the visits will be conducted, and essentially you have a visit 0 and visit 1, which is screening and randomization, and then the following visits occur at every 4 months until we complete a total of 7 visits at the end of the study, which is a 2-year study, the 1 year of intervention and 1 year of follow-up, during which several assessments will be done. There will be assessments of resolvents and mechanistic studies to try to actually not only see at a metabolic effect, but rather to look at the mechanism. Can we identify a mechanism? Can we identify maybe what is the optimal ratio that is required to have an effect on the resolving pathway? And again, whether that correlates with an effect in beta cell function and beta cell mass. So now, let me talk a little bit about the recruitment status of this particular trial. There have been, thus far, this is data up until the beginning of April, 129 participant contacts. 89 applications have been sent and have been reviewed. Again, remember this started in July last year. 68 patients have been determined to be eligible for screening. There have been 22 visit cancellations, patients that actually were going to come but ultimately canceled the visit. 30 visits have been completed, and there have been 13 screen failures. And a good portion of this has been children that may have had diabetes for several years, and we know that in them the disease progresses much faster, so even if we catch them at 2 years after diagnosis, they may not have C-peptide anymore. So those are one of the main reasons that we also see, particularly in younger children, if we catch them a little bit too late. There's still 16 pending visits, and another important aspect is that mostly children have been enrolled to date, and I think this also highlights the interest of parents in regards to this particular intervention and their motivation to try to get their kids into these clinical trials. It has been really challenging with adult enrollment. And the most challenging issue, it seems to stem from the fact of requiring time off from work and school. Those seems to limit significantly because we don't only get referrals within Miami, but we get referrals outside. So time from flights to come in, to be randomized, to be tested, is a little bit challenging, right? But so we need to raise awareness, and hopefully our recruitment will increase and boost up. Another important aspect is that tolerability to high-dose fish oil so far has been very good. And most importantly, there has been no study-related serious adverse events to date with this intervention. So to finalize, it's important to acknowledge all the people that make this clinical trial happen. We have the Poseidon team, with Dr. Ricordi, Dr. Alejandro, Dr. Janine Sanchez, Dr. Padilla, and Alvarez, our coordinators. The regulatory team, Dr. Hirani and Luis Roque. We have collaborators, Dr. Alberto Pugliese, Gloria Allende, who will be taking care of doing the autoantibody assays, Dr. Michael Clare-Salzer, who's here today, and Timothy Garrett, who will be helping us with the resolving assays, and the investigational product, who has kindly been provided by Dr. Barry Sears, and the CRC staff, and ultimately the Diabetes Research Institute Foundation for their support for the conduction of this study. And with that, I'll end, and I'll take any questions. Thank you.
Hello. This is Isaac Snowwhite from Dr. Puglia's lab, and I feel sorry because this is a question actually I wanted to ask a few ago, but it's sort of overlapping. There's a heavy focus on a recurring theme about Japanese diet and fish, which also includes algae and certain seeds. Like I was curious, other plant-based sources like chai or well, anyway, basically there are other plant-based sources of omega-3 that are actually much higher than fish, and you would probably have fewer issues with the pollution issue contributing, to diet pickup from environmental sources.
Yeah, I refer this question to Dr. Sears, who's our expert.
Algae consumption or seaweed. So my question is, what's the data on the plant-based sources?
This is very serious addressing your question. The plant-based sources of omega-3 fatty acids consist almost...
Sorry, I can't hear.
Okay.
Right, it seems to be off for some reason, the microphone there. You may want to come. Yeah.
Coming.
Yeah, I'm sorry. I should have gotten you guys early. I tried to write it on the Zoom thing, but it looks like the feed doesn't go through to anything.
The plant-based sources that people talk about as sources of omega-3 fatty acids contain short-chain omega-3 fatty acids. These are primarily alpha-linoleic acid.
Right.
These fatty acids are very slowly and inefficiently converted to EPA and DHA. The data is quite clear. It takes you nearly 50 to 100 times the volume of short-chain omega-3 fatty acids to get the same levels of the long-chain omega-3 fatty acids found in fish
But you also
oil.
receive 20 times as much in its consumption.
Well, but the consumption, the Japanese do not eat a lot of, basically chia seeds. Chia seeds.
Well, I was thinking algae, actually. Seaweed.
Algae contains primarily EPA and DHA, just in very low concentrations. So algae does not contain virtually any short-chain omega-3 fatty acids. It's low concentration, so you have to eat approximately about a kilogram a day of algae to get the same levels of the consumption of omega-3 fatty acids the Japanese get in terms of fish consumption.
And fermented foods as well, like the soy?
Fermented food, soy basically contains no long-chain omega-3 fatty acids, nor do fermented foods. You will only find preformed long-chain omega-3 fatty acids in either seaweeds in very low concentrations or in higher concentrations in terms of the long-chain fatty acids in fish. Notice when we are talking about the levels of arachidonic acid EPA, the levels of the Japanese are incredibly low compared to Americans.
Mm-hmm.
So from the standpoint that saying that there are other societies, again, in terms of Italy, I'll use an example, who eat a lot of plant-based sources which are rich in omega-3 fatty acids. Their levels of arachidonic acid to EPA are much, much higher than the Japanese.
What about flaxseed? A lot of people ask about flaxseed.
Or chai, or flaxseed, or hemp, or there's a bunch of them. But
flaxseed is very rich in short-chain omega-3 fatty acids. Nearly 50% of the fatty acids in flaxseed are alpha-linoleic acid.
I think it's like 19.5 grams per 3-ounce serving or something like that.
But again, the conversion is incredibly slow and inefficient. This has again been shown over and over again. Your conversion rate of alpha-linoleic acid into EPA is at best maybe 5%, and the conversion of alpha-linoleic acid into DHA at best is under 1%. So these are not very good sources of the long-chain omega-3 fatty acids. And again,
I'm just saying that based on that dose, if you consume like basically a tablespoon, that comes up to about 1 gram per tablespoon based on your conversion rate, right?
Yes, but now if you look at basically the levels of arachidonic acid to EPA in the blood of those individuals. Again, our best data comes from the Italian population. They eat a fair amount of plant-based omega-3 fatty acids. Their levels, their ratio of arachidonic acid to EPA is conceptually much higher than that found in the Japanese population.
I was also curious about the balance of their dietary intake. So the consumption of meat in general is also much higher.
That's why we had to look at the diet. It's not the amount of meat per se. It's really the ratio of the protein to carbohydrate, and so because that will basically affect the enzymes that convert the alpha-linoleic acid into the longer chain omega-3 fatty acids. These enzymes, these delta-5 and delta-6 desaturases, are basically strongly influenced by the levels of insulin and glucagon produced by the ratio of protein to carbohydrate in the diet.
Here we go. The volume a little higher. Sorry about that. Thank you. Sorry. Thank you for the answer.
We have another question from the Instagram live streaming. Like, if you are vegan, are you doomed that you cannot do this protocol, or there are alternatives?
No, there are alternatives. There are vegan sources. Basically, these are algae mutants that can basically make both EPA and DHA. For years, the only algae source that could make long-chain omega-3 fatty acids was only making DHA. So there are now mutants that basically can make both these omega-3 fatty acids. So the vegan is not doomed to death.
And where can you find the algae mutants?
You can find them in, several. There were products, but there was no demand for it. But you can find them on the internet. Basically, that again, and they're good quality products. They're expensive, but they basically are not bad products as ideally suited for the vegan.
Wait. Bring in the mic.
One of the challenges of the study, you said, was the amount of time that adults have to take off of work. Are you doing blood spot finger testing, and could they do that at home?
No, we're not doing finger spot testing. I'm not familiar actually with the data and with the validation. We wanted to go with a standard assay. It may be that it's validated and we could use it. We just wanted to keep it in the context of other previous studies that they've used particular assays for vitamin D levels and so forth. So that's why we decided to keep it in that particular. I'm not too familiar, again, on the spot assays. Yeah.
David, just a couple questions. Sure. One is on the vitamin D, given that 125 is the bioactive forms for inflammation suppression, and there's polymorphisms in the 1-alpha hydroxylase. I don't remember the frequency, but you might, it would be great if you could measure that. That's just one comment. The other thing is, in the young population, where you tend to see the earlier, lower C-peptide responses, the question I have is, and I don't know that people have looked at this, and it's mostly glucose-based C-peptide response.
Correct.
So the question is, if beta cells are really blind to glucose-stimulated insulin secretion, is it possible that if you included some of those that were failures, so they couldn't enter the study, and gave them a trial of D and omega-3s, could you resuscitate or demonstrate resuscitation of the beta cell function? It might help with the enrollment in your trial, and it may lead to, there's no response. But I don't think that it's really been looked at.
No, it's true. I mean, I don't think there's studies looking at non-glucose secretagogues in those particular patients to see how much a residual mass that is just not responding to glucose is available. I mean, we clearly know that you lose your ability to secrete to glucose, but you may still have ability to secrete to arginine, and you still have a measure of, it's an impaired beta cell, but it's not dead.
But we don't know as well that the glucagon response and the arginine responses are likewise not somehow modified by the inflammation within the islet. So yeah. I think it might be worth doing a little pilot trial to see if any of those failures that don't get enrolled, you can enroll in a pilot trial to just put them on anti-inflammatories for X amount of time, probably keeping that duration less than 10 years, because I think you may have an issue there. Yes,
I think, it would be interesting first to assess whether we have a measure to look at if they still have some sort of response, right? Yeah. And secondly, if we are able to identify from those patients, they still have beta cell mass that you can salvage, right, to intervene. But again, that will be separate. It will be a different study, but we could certainly start at least an exploratory.
But you've got them coming in, so maybe you could end up using.
Yeah, exactly. So. Yeah, I agree.
Another limitation, more than the traveling time, David, more than the traveling time as a limitation for enrollment. I think that the other major limitation is that I publish open access on Cellar for the entire protocol, so that adults that may say, well, why shall I go and flip the coin when I can just do the protocol with supervision of my physician or doctor? And we have at least one example here in this room. That is, is one of the problems. Such a simple, safe, and cheap intervention that we know that there are hundreds of patients that are doing it, including the ones that are discarded because they don't have enough C-peptide at baseline. So, but thank you so much. So if